talking on very interesting subject like ICDs, which are life-saving devices. And to moderate this session, we have Dr. Sanjeev Kathuria, and he's a very good friend of mine. He is associate professor at GE Panth Hospital. So without delay, let me hand it over to Dr. Sanjeev to moderate the session and start the proceedings. Dr. Sanjeev, over to you.
Yeah, very good. Good evening, everybody. Another session. I think this seminar, these sessions started by Dilip are really good because they're catering to your basic needs. At the same time, you're able to show some, in the last 4 sessions, you were able to see that they've shown some ECGs which help you actually groom up whatever you have learned. So they're really nice sessions. Without wasting time, I'll ask Dr. Bikash Majumder to start with his presentation. Dr. Bikash is a senior consultant cardiologist at Apollo Hospital, Calcutta. He is the clinical tutor for Apollo Hospital Education and Research Foundation. At the same time, he is the founder director of cardiology master classes working for education of junior doctors in Calcutta. At the same time, he is the chairman and founder trustee of West Bengal Heart Foundation, an NGO working towards spreading awareness about heart disease among common patients and people. So I think the introduction itself is saying that he's going to do a lot of justice to the topic. So without wasting any time, over to Dr. Bikash.
Okay, thank you, Sanjeev. Is my slides visible?
Yeah, we can see it. We can see the slides.
Yes. You can see slides, yeah. So, good evening, everyone. So, today my topic is on indication of ICD. Is it still relevant in non-ischemic dilated cardiomyopathy as primary prevention? So, we all know that primary prevention means patient didn't have any event of ventricular tachycardia, and patient has LV dysfunction, but there is no evidence of ischemic heart disease in those kind of patients. We all know that ischemic heart disease patients with LV dysfunction, ICD indication is the class 1 indication if patient have significant LV dysfunction with ischemic heart disease. But in non-ischemic heart disease with LV dysfunction, the evidence is not quite agreed upon, and it varies depending on which trial or which kind of trials you are looking at. So I'm just going to discuss few things today, and we'll see what we can learn, and we can discuss about the indications of ICD as a primary prevention in non-ischemic DCM. So there are multiple randomized trials which have been reported regarding the ICD in primary prevention of sudden cardiac death in patients with non-ischemic DCM. And we know that 30% of the death in patients with DCM are sudden, and mortality in medically treated patients with DCM and a prior history of syncope makes it 30% at 2 years. Whereas those treated with ICD experience a high frequency of appropriate ICD therapy. So this is something that we know about DCM. Now, when we look at different trials on non-ischemic DCM, and I will discuss few trials. First, the early trial was a CAT trial. It was a primary prevention trial of DCM of recent onset, 9 months in average. Patient had impaired LV ejection fraction, that is, ejection fraction was less than 30%, and patient was in either class 2 or class 3 NIHA class. And there was no significant coronary stenosis, more than 70%, and it was excluded by an angiography, and without documented symptomatic ventricular tachyarrhythmias, and patient was randomly assigned either to an ICD therapy group or to a control group. And the primary endpoint of the trial was all-cause of mortality at 1 year, and total of 104 patients were enrolled between the 1991 and March 1997. So it was a very early trial, and at that time you all agree with me that heart failure treatment, medical treatment of the heart failure was probably not as established as today. And of course, the CRT indications were not that robust in the early 1991 as it is today. So 50 patients were randomly assigned to ICD treatment and 54 was in the control group. And if you look at that result, there was no significant difference in survival in the ICD group compared with the control group. So this is a primary prevention trial, and it was a negative trial. And all-cause mortality rates were neither different between ICD treatment and control group after 1 year, nor during the long-term follow-up. And short and long-term overall mortality rate in patients with DCM and significantly impaired LV function was surprisingly low. Therefore, ICD therapy did not provide any survival benefit in these patients. So ICD therapy did not reveal any survival benefit in the setting of DCM with LV ejection fraction less than 30% if it is a non-ischemic DCM and if you are using ICD as a primary prevention. So CAT trial was a negative trial. It did not favor prophylactic ICD implantation in patients with non-ischemic DCM with an LV dysfunction with an LV ejection fraction less than 30%. Now, the lack of survival benefit of the ICD therapy is most likely due to the overall low event rate in that particular cohort where this study was performed. And even if the study had been continued to include 1348 patients, the power to show the expected difference of 6% would have been 50%. Thus, the trial was stopped because it was a futile trial to continue. So after 1 year, the trial was actually stopped and it didn't show any benefit. That was a very early trial called CAT trial. So in our practice, we often give amiodarone treatment to the patients with LV dysfunctions if we get some kind of non-sustained VT. So another trial I would like to talk about is AmioVert trial. Again, the background was to compare total mortality in patients with non-ischemic DCM and asymptomatic non-sustained VT randomly assigned to therapy with amiodarone in one group and ICD on the other group. And subjects were randomly assigned to receive either amiodarone or ICD. Inclusion criteria again was non-ischemic DCM, and in this particular study, the ejection fraction cutoff was taken as 35%. So anyone below 35% was included, and the patient also had asymptomatic non-sustained VT, and patient was in New York Heart Failure Classification Association functional class of 1 to 3, and patient's age was 18 years and above. Because in our clinical practice, we often see the patients getting some non-sustained VT with an LV dysfunction. Many physicians are very prompt to start some amiodarone treatment on these patients. And in this particular trial, we compared actually the amiodarone versus ICD in this cohort of patients where there is only non-sustained VT. And the primary endpoint of this study was total mortality. Secondary endpoint consisted of sudden cardiac death, non-sudden cardiac death, non-cardiac death, syncope, and arrhythmia-free survival and quality of life and costs. So if you look at this trial, there was again no significant difference between the amiodarone and the ICD group in the cumulative survival in this particular study. And at the first interim analysis in September 2000, the study enrollment was discontinued because of inability to demonstrate any statistical significance in this particular study. The 1 and 3 year survival rate among the 52 patients treated with amiodarone compared with 51 patients treated with ICD was not significant either. And there was a trend towards improved arrhythmia-free survival with amiodarone therapy. The quality of life with each therapy was not statistically different, but of course cost was lower in the amiodarone group. But there was, in this particular AmioVert study, there was no significant difference between the amiodarone and the ICD as far as the survival is concerned. Next come the Decode trial. So the background of this particular trial, the hypothesis was an ICD will reduce the risk of death in patients with non-ischemic cardiomyopathy and moderate to severe LV dysfunction. It was a prospective trial. It was randomized. It was investigator-initiated study. Left ventricular ejection fraction here, they took less than 36%. And the presence of ambient arrhythmias, a history of symptomatic heart failure, and the presence of non-ischemic dilated cardiomyopathy, these were the inclusion criteria. And the methodology said patients were randomly assigned to one of the two treatment groups with 229 patients in each group. patients who were randomly assigned to ICD group received a single chamber ICD only. They didn't receive dual chamber ICD. And if you look at the outcome, the death from any cause did not have any significant difference between the standard therapy group and the ICD group. And sudden death from arrhythmia was less in ICD group compared to the standard therapy group. So fewer patients died in the ICD group than the standard therapy group, but it didn't actually reach the statistical significance. You can see in the ICD group, there are 28 deaths compared to 40 deaths in the standard therapy group, but the p-value was 0.08, which did not reach the statistical significance. But there was ICD group, there is a significantly reduced the risk of sudden death from arrhythmia. So that was important. So definite study in that aspect was, going more in favor of ICD because the ICD group actually showed that patient had less incidence of sudden arrhythmic death. And that was, though the total, all-cause death was not particularly different in these two groups. And subgroup analysis revealed that implantation of the ICD significantly reduced the risk of death among patients with NIHA class 3 heart failure and among the men. So men, man with NIHA class 3, if you put an ICD with a non-ischemic dilated cardiomyopathy with ejection fraction of less than 36%, probably will have less sudden cardiac death if we put an ICD on that particular gentleman. That's probably the conclusion of this particular study. So on the basis of this result, the routine implantation of the cardioverter defibrillator cannot be recommended for all patients with non-ischemic cardiomyopathy. However, the findings of reduction in sudden death from arrhythmia and an apparent benefit of the ICD in this subgroup analysis suggests that use of these devices should be considered on a case-by-case basis, but it cannot be given to all the patients with non-ischemic DCM. Now, next comes another study called SCADHEP study. And this is the study on the basis of which the American Heart Association actually recommended ICD for non-ischemic cardiomyopathy. Now, this particular study was the only study which actually they recommended on it, but Europeans don't agree on the on the recommendation of the American Heart Association. The reason I will tell in this particular study that this is a SCADHEP study designed to evaluate the hypothesis that amiodarone or single-lead ICD would decrease the risk of death from any cause in broad population of patients with mild to moderate heart failure. It is a placebo-controlled, 3-arm study, intention to treat analysis. 2,500 patients were included, and patients were in NIHA class 2 and class 3 CHF, and left ventricular ejection fraction should be less than 35%. So these are the inclusion criteria of these patients. Now, patient have stable CHF due to ischemic or non-ischemic cause. Anything can happen in this particular, if they took ischemic as well as non-ischemic. Conventional therapy for CHF plus placebo received 847 patients. Conventional therapy plus amiodarone was received in 845 patients. And conventional therapy plus single-lead ICD, 829 patients. And placebo and amiodarone was administered in a double-blind fashion. And the primary endpoint was death from any cause. Now, if you look at this particular slide, if you see in the amiodarone versus placebo group, there is no significant difference as far as mortality is concerned. But ICD therapy versus placebo, you can see there is 23% reduction in all cause of mortality in SCADHEP study. Now, if you look at the mortality in the ischemic CHF group, here we see that ICD therapy actually reduced 21% mortality with a p-value of 0.05 in the ischemic CHF group. In the non-ischemic CHF group, yes, ICD therapy reduced 27% mortality, but it was not statistically significant as far as the all-cause mortality is concerned. But if you look at the NIHA class 2 patients, and if you compare that, if you can see clearly that ICD therapy compared to the placebo had significant reduction in mortality, and the p-value you can see is less than 0.001. So ICD therapy in the NIHA class 2 group with class 2 NIHA symptoms had significant benefit over the placebo therapy, where amiodarone didn't show any benefit in this particular group. If you look at the NIHA class 3, again, there is no significant difference between the placebo and the ICD therapy group in SCARDEF trial. So ICD significantly decreased the relative risk of death by 23%, resulting in an absolute reduction of 7.2% at 5 years among the patients with CHF. Amiodarone had no effect. ICD therapy has a significant benefit in NIH class 2, but not in class 3 CHF. And amiodarone therapy had no benefit in patients with NIH class 2 and decreased survival among patients with NIH class 3 CHF as compared to those who received placebo. So again, very conflicting. You know, it helps in NIH class 2, doesn't help in NIH class 3. Again, NIH class 2, if you put the ICD, they have significant difference. But in NIH class 3, it doesn't show much difference. In total mortality, if you look at, then again, there is no significant difference. The SCARDEF trial, though, showed some amount of improvement with ICD, particularly in NIH class 2 symptomatic patient with non-ischemic DCM. But I wouldn't say it's a very convincing trial to suggest that everyone with non-ischemic DCM should have ICD put in as a primary prevention. And we all have to remember that in SCARDEF trial in those days, the patients which were recruited were neither receiving adequate dose of beta blocker, nor receiving the adequate dose of mineralocorticoid antagonist, and at the same time, not many patients had CRT, as we are treating those heart failure patients with the CRT nowadays. So it was again an old study, and probably all the patients didn't receive the adequate heart failure treatment that one should particularly receive. The most recent trial is the Danish trial. Again, the objective of this trial was to investigate the effect of ICD implantation in patients with heart failure and reduced ejection fraction not caused by coronary artery disease and who receives contemporary heart failure treatment, including CRT. So Danish trial actually included those patients who also had CRTs to see if ICD has any additional benefit if in those patients who had CRT and compared to those patients who didn't have a CRT. And Danish study added insight into the rate of complications in a cohort where a large proportion of patients will require implantation of multiple leads. So the method, again, it was a multi-center study. It was randomized, unblinded, controlled, parallel, and two-group trial. And inclusion criteria: patient have to be in clinical heart failure, it's non-ischemic etiology, optimal medical treatment. This is very important. The patient before recruitment should have optimal medical treatment, and NIH functional class was 2 and 3, and only the NIH class 4 was included if there is a plan to implant a CRT on that particular patient. And again, the LV ejection fraction cutoff was less than 35%, and patient should have an NT-proBNP of more than 200 picogram per mil. So primary analysis of this particular Danish study was time to death from any cause. And secondary outcome was time to sudden cardiac death, time to cardiovascular death, time to resuscitated cardiac arrest or sustained ventricular tachycardia, change in quality of life from baseline, and it was assessed by the Minnesota Living with Heart Failure Questionnaire. And result was total 1,116 patients were enrolled in the 5 centers. 556 patients were randomly assigned to the ICD group. 560 patients were assigned to the control group. Follow-up data, all outcome were available through June 30, 2016. The median follow-up period was 67 months, and no patients were lost to follow-up for the primary outcome. And if you look at the outcome, then cumulative event rate, like primary outcome of death from any cause, occurred in 120 patients in the ICD group and in 131 patients in the control group. The hazard ratio for death from any cause in the ICD group as compared with the control group was 0.87. Now again, there is 13% reduction of death in all cause, but it was not statistically significant as far as the all cause of death is concerned. Now cardiovascular death, if you see that in the ICD group was 95 and in the control group sorry, in the 77, and in the control group it was 95. Again, there was no significant difference as far as the cardiovascular death is concerned between the ICD group and the control group. And sudden cardiac death, yes, there was a significant difference in the ICD group compared to the control group as far as the sudden cardiac death is concerned. Now, it is 24 sudden cardiac death in the ICD group compared to the 46 patients who died in the control group, which was statistically significant. So Danish study said there is a significant reduction in the sudden cardiac group death if we put ICD on those patients with non-ischemic DCM with ejection fraction less than 35%, but there is no significant difference in all-cause mortality or cardiovascular death. Now, implantation of the ICD in heart failure not caused by ischemic heart disease did not prove an overall survival benefit, although the risk of sudden cardiac death was halved with ICD. So no difference of ICD between the patients who had CRT or patient who didn't have a CRT. So if you are putting a CRT and putting a CRTD as a primary prevention, actually there is no significant difference between CRT group and the CRTD group as far as the primary prevention is concerned. So putting CRTD in everyone where we are putting a device for a primary prevention with someone who's less than 35% is probably not the right way to go in non-ischemic DCM. So time to event curves diverge during the initial 5 years and then converge. And this particular study actually generates the rationale for doing a long-term studies, particularly in the current days where many patients were getting with CRT, and then see if addition of ICD to the CRT devices will help in the long run in those patients or not. But currently, there is no data to support that those patients who we are putting a device for primary prevention, every patient should be having CRTD rather than only CRT as far as the total mortality is concerned. So 31% of the deaths were due to non-cardiovascular causes. Important interaction with age. Younger patients had a better survival benefit with an ICD in this particular study compared to the older patient. And this is not surprising as in an elderly population, but it highlights the importance of selecting patients for ICD implantation carefully, and patient and higher risk more likely to benefit from ICD. So if I summarize all this study, so look, from the CAT, it actually took an inclusion criteria of less than 30% ejection fraction. Patient was in NIH class 2 or 3. And ICD versus optical medical treatment. Follow-up was 66 months. There was no significant benefit as far as the CAT study is concerned from ICD. AMUVERT, they took an ejection fraction less than 35%. Patients were between NIH class 1 and class 3. All the patients has non-sustained VT. The comparison was between ICD and amiodarone. Follow-up was 24 months. There was no significant reduction in mortality as far as these two groups is concerned. DEFINITE trial is another trial. Again, ejection fraction was less than 36%. NIH class 1 to class 3. Patient also had PVCs or NSVTs. ICD versus optimum medical treatment, that's the question we looked for. Follow-up was 29 months. And again, there is no significant difference in all-cause mortality in these two groups. But of course, we found there is 80% reduction in sudden cardiac death in the DEFINITE study in favor of the ICD. SCARHEPT is another trial, ejection fraction less than 35%. NIH class 2 and class 3 patients. ICD versus optimal medical therapy versus amiodarone was tried in this particular trial. Follow-up was 46 months. Again, there was no significant reduction. And Danish trial, again, we can see less than 35% ejection fraction. Patients were in NIH class 3 and class 4 only if CRT was considered. At the same time, patient had to have an NT-proBNP of more than 200 as an inclusion criteria. We looked at the difference between the ICD group and the optimum medical treatment group. Follow-up was 68 months. And again, there is non-significant reduction, but there is a reduction in the sudden cardiac death, which was about 50%. So if you look at all these studies, the DEFINITE and the Danish study, these are the two studies where they showed that the benefit of ICD in reducing sudden cardiac death, but it did not show overall mortality benefit in these two studies with ICD. Now, if you look at the recommendations, now from the American Society, it still says that class A recommendation patients with non-ischemic cardiomyopathy, heart failure with NIH class 2 and 3 symptoms, and LVEF of 35% or less, despite guideline-directed medical treatment, and ICD is recommended if meaningful survival is greater than 1 year is expected. So that is still the recommendation of the American societies. So ICD implantation for primary prevention of sudden cardiac death in patients with symptomatic systolic heart failure is a class 1 recommendation with no differentiation between the ischemic and the non-ischemic cause by the American societies. Now, this is solely based on the basis of the SCARHEV trial for the recommendations regarding the ICD implantation in patients with non-ischemic cardiomyopathy, whereas the European guidelines refer mainly to the DEFINITE trial. And however, SCARHEV enrolled patients in 1997 and 2001, and only 69% of the enrolled patients received beta blockers at baseline, and 20% of the patients received mineralocorticoid antagonists, and no patients received any concomitant CRT. And at the same time, the SCARHEV, the patient didn't have an angiography. All patients didn't have an angiography to rule out ischemic heart disease in those patients. They are all clinically assessed. So you cannot, depend your guidelines only on the basis of the SCARHEV trial in today's world in 2020. So in the take-home message, ICD therapy is of benefit among appropriately selected few patients of non-ischemic cardiomyopathy, particularly if they are younger, and ICD therapy is not beneficial for everyone with severe non-ischemic LV dysfunction. And among patients with CRT, there is no statistically significant difference in mortality between CRTD and CRTP group. Further research on the efficacy of defibrillator therapy in patients with CRT is needed. And even today, when the ARNI has come in the heart failure treatment group, further investigation is also needed with ICD, CRT, and ARNI to come up with new recommendations regarding the role of ICD as a primary prevention in non-ischemic cardiomyopathy. Thank you very much.
Hello. Yeah.
Hello.
Yeah. Thank you, Dr. Majumder. Really exhaustive one. Really covering a lot of aspects, but there are some issues we need to cover. Exactly speaking about NI, non-ischemic cardiomyopathy, the rule, what Danish started and what Danish wanted to do was to think what the SCARHEV has done. The SCARHEV had established that in patients where you require an ICD per se, where the QRS is not a consideration, you have a role of ICD. The SCARHEV did it. But the difference in the Danish trial was that most of the patients were on CRT. So there you're talking about patients with QRS which is prolonged. So I think Danish people wanted to study the way SCD heft was there, but they answered something else. They answered what is the role of ICD in patients requiring CRT. So they answered something else. Now the basic difference I feel in this trial, which you also mentioned very well, between the Danish and this trial is the fact that in the Danish trial, most of the patients were requiring CRT, and the concept here comes into picture is patients who are given CRT in DCMP over time will have a reduced in the sudden cardiac death because of the remodeling phenomena, the reverse remodeling phenomena because of CRT. So your last slide, which very clearly states that you'll have to choose people in NIDM to decide, is dependent on a lot of factors, particularly the etiology. Non-ischemic cardiomyopathy is a dustbin phenomena where they've included so many things. But there are some indications where it might be required in a class 2 or class 3, where class 2 was much better. But in some, you might have to wait. But that's what I feel. That the addition of Danish has nothing to do with going out of type 1 indication of NYH2, 3 ejection fraction less than 35%, people requiring ICD in non-ischemic. It stays because Danish is with respect to QRS being prolonged. So there is a shift in the focus. So the class 1 recommendation still stays even despite the Danish trial, because Danish trial subset is a little different. It is a subset where CRT is required. It's a subset with a QRS which is prolonged. That's what I feel.
This is, the American guidelines is, as I said, is only established on the SCARHEV trial for the non-ischemic cardiomyopathy. But, the Europeans are not that convinced with this SCARHEV to cause a class 1 indication for non-ischemic cardiomyopathy as a primary prevention. Yeah, there is a difference. There is a difference between these two schools. But anyway, it's a difficult scenario. But from the clinical management point of view, I think we have to, in the young patients with severe LV dysfunctions, we have tried all these, optimal medical treatment, and then yes, there is probably an indication of putting a ICD on that particular patient.
I feel this all is.
I
think this is all influenced by a simple phenomena. The simple phenomenon which is influencing all this is the load of sudden death. You see, as the class is changing, how much is in that class the sudden cardiac death is contributing to the mortality. So that's why in 2, 3, the NYHA class is very, very important, because the contribution of sudden cardiac death to that class will certainly make a lot of difference. In fact, in
probably most of the sudden cardiac death is arrhythmic. Probably, means it's not clearly mentioned. It's not clearly mentioned. Probably it will be all arrhythmic.
In fact, I feel, Dr. Majumder, there's a new concept which has come in primary prevention, which is the 1.5 prevention. Because people are saying you'll have to go above the QRS. Our whole focus in all ICDs is QRS. I feel it has to go above QRS. And that's what everybody is saying. In a primary prevention, QRS duration, QT prolongation, history of NSVT, syncope, all should be added. And that's why genetic trial taking this, the symptoms and the phenotypic features are now coming up. People are working on genetics.
See, it is important to risk stratify a subgroup of patients. I think we just can't say blanketly everyone needs it, but of course, as a physician, we need to risk stratify and which patients will be more prone to have sudden death, and definitely we have to protect them with a primary prevention ICD.
I have a question for you, Dr. Majumder. Can you hear me? Hello?
Yeah.
It was an excellent presentation. First, let me congratulate you. And my point is regarding the, when you started some patients on with the LBB, 30% ejection fraction, we put this patient on a CRT, and the ejection fraction goes to 40-45%. In the next 6 months, what is the extra benefit of putting an IC lead there? Number one. And second, do you have any data and statistics regarding any trials which has been they have taken into consideration regarding the myocardial scar by an MRI or imaging technology, just like in HCM, hypertrophic cardiomyopathy, where it has been proven that 10%, more than 10% of myocardial scar, it shows that these patients, these group of patients will have more chance of SCD. And this is an independent predictor of SCD, and you can go for an ICD implantation.
Definitely. So if CRT patients improve, as you said, by more than 45%, and it's a idiopathic DCM, and you are not talking about any scar or anything like that, like an infiltrative or any other cause, then I don't think that we should be upgrading it to CRTD. That's I don't see any recommendation to do that.
I was just asking, if the patient had a CRTD at the first place only, then this ICD lead after the ejection fraction goes more than 40-45% becomes superfluous. So my idea was, why not to look at myocardial scar? If there is no scar, we can just sit down. If the patient has a narrow QRS and he is perfectly doing fine, maybe 30%, no past history of NSVT or VT. So with this, inadequate statistics and data available to us, maybe a reasonable idea for an MRI. So are there any studies which relates MRI, scar and ICD in primary prevention?
I can't just remember at this moment any particular study I am not aware of, but in my clinical practice, I can just tell you I did a ICD on a patient. Of course, that was a secondary prevention patient, but we often see these patients. So just give you an anecdote, an example of a patient I treated a few months ago, and even he came yesterday in my clinic. This guy is a 50-year-old guy. He presented with hemodynamically significant VT, monomorphic VT in the OPD, and ejection fraction was 48%, right? And normal coronary angiography, and it was a monomorphic VT, normal coronary angiography. He had incessant VT, and we had to shock him a few times to come out of this VT. Then we did a cardiac MR, and there was a significant scar in the myocardium with a normal coronary angiography. And this patient had a background history of ankylosing spondylosis. Now, then I had to, of course, definitely put an ICD as a secondary prevention in this particular case. But this is the first episode of VT at the age of 55, at the age of 55. So if we could have picked up this patient 5 years ago, what you would have done? Do you understand? If you see a patient with an echo of 48% and you don't see any VT, but if you do an MR, then probably you'll get a scar. And will you put an ICD prophylactically in that particular patient? We don't have that guideline, do we? That with a 48% ejection fraction with a significant scar in the myocardium who hasn't had a VT, will you put a ICD in that particular patient prophylactically? That's my question. Now, this patient had a VT, so I definitely, he went into secondary prevention. So I had to do an ICD. But if I have seen this patient 1 year ago, should I put ICD? I don't know.
Dilip, can I come in?
Sanjeev,
Yeah.
Dr. Sanjeev Mukherjee.
Yeah.
Sanjeev,
Yeah.
about any MRI based any study, less ejection fraction, 35%, where an MRI guided ICD is being implanted, or in primary prevention, narrow QRS. Do you have any idea?
No. Offhand, I don't remember a trial like this. Yeah, I don't have. No.
I think, yeah.
But I agree to a point. That's risk stratification is definitely something that we should look at this time. If not every patient is same, and as I agree with that, this MR is definitely a point that should take it. Dr. Sanjeev wanted to speak something. Dr. Yeah, come in.
Coming to the first question which you asked, you were very categorical in asking a person having ejection fraction of 30, and now you're thinking of giving a CRTD and a CRTP. That's the differentiation you wanted. So the Danish is already taking care of this thing only. That's what it is trying to say. In a DCMP, it says, since the scar burden is less, so your problem will be solved by a CRT more, because the CRT is expected to do a reverse remodeling, and it is expected that ICD will not be required. That's where the answer is coming. So this gray zone of having an ICD in non-ischemic cardiomyopathy, NYHA 2-3, is now with respect to the fact that you will have to understand that if it is the CRT, if it's a QRS which is wide, then probably it is not required per se right now, because it said that QRT wide will have a reverse remodeling if you are just having a dilated cardiomyopathy. That is why the effect of CRT is very good on them. While if the QRS is normal, then you stand a chance and you have a reason to believe that the ICD will be helpful. So your first question very much pertains to the fact that where is the role of ICD in that patient? There, Danish is saying it doesn't have a role. As far as the second question, the second part which you're discussing, MRI is in fact going to become a backbone now. Because if by LG totally correlates with the scar burden and totally correlates with the arrhythmic burden. That's what the new study, in fact, a meta-analysis has also been published, which very clearly says that in fact, getting to the scar burden might be the answer in the future. What are we assuming? We are assuming CRT in DCMP is without scars, and that is why it is not required. Because in CRT and ICMP is with scars. That is why it is required. So if you are able to document a scar burden of more than 15%, and that is an LG in T1 weighted images correlates very well, because LG actually is T1 images only which are exaggerated with the help of gadolinium. So if your fibrosis is more than 15% enhancement, then it is a very, very good chance of correlating with the requirement of ICD. In fact, this will become one of the modalities in future. And now the future of this MRI, in fact, is now gadolinium enhancement, transmural or not. If you have a transmural enhancement, you will have what sir was just telling about a patient. Transmural enhancement means you have a dead myocardium, probably a homogeneous scar, where monomorphic VTs are more likely to occur. And if you have a less than transmural enhancement, then that means you have a heterogeneous scar, viable as well as non-viable myocardium. Both of them requiring an ICT, but probably this all characterization will come clear with MRI. So your question is very valid. Using these criteria of QRS, QT prolongation, add on to them MRI, it is going to become a very big modality for deciding whether ICD is required or not.
You can move for the second presentation, Dr.
Yeah.
You can introduce Dr. Sanjeev.
Yeah, it's my pleasure to introduce Dr. Sanjeev Mukherjee. He's a senior consultant cardiologist and electrophysiologist in Medical Super Specialty Hospital, Kolkata. He completed his fellowship in EP from Care Hospital, Hyderabad. He's a member of Cardiology Society of India and Indian Rhythm Heart Society. He possesses a vast experience as a presenter in national and international conferences with many published abstracts and articles by his name. So I'll just request Dr. Sanjeev to come with his talk.
Thank you, Dr. Sanjeev. Respected chair and dear friends, good evening. So my topic today is to so this is my topic today. I'll be talking on SVT bar VT discrimination in ICD. Now, as we just discussed, there is no denial now at this moment that ICDs save life, in terms of both primary prevention and secondary prevention. There is enough data now to suggest that ICDs prolong life, saves more life, and is a definite form of treatment that we all are aware of and must utilize it. But having said that, gradually as time is passing, more and more data is accumulating. And we have realized that in addition to saving lives, there is another arm to ICDs, and that is about inappropriate therapies. Now, if an ICD delivers an inappropriate therapy, and when I say inappropriate therapy, the definition is very clear. You are putting an ICD for ventricular arrhythmias. It has to be either a VT or a VF that the device is going to detect and treat. If the device is going to deliver a therapy for any other arrhythmia, if it is an SVT or it is wrongly considered arrhythmia, it is all that is binned into something called as inappropriate therapy. So now more and more as we see, we find that inappropriate therapies are also forms a large chunk of therapies that the ICD deliver. And what is the problem with this? Inappropriate therapies increases mortality. If the ICD delivers inappropriate shock, it is going to increase mortality. And therefore, it becomes very essential for us to make sure that we program our patients, every patient as a separate case, and program him appropriate to his disease process, to make sure that we reduce inappropriate shocks, because inappropriate shocks increases mortality, causes psychological trauma. Now, what is the data that is saying? If you see the data, then it says that if you put ICDs in 100 patients, 13 of them will receive inappropriate shocks. And if you analyze 100 shocks, then about 30 of those shocks are inappropriate. So that is a very, very large chunk of therapies that are going inappropriate. What about the duration? When our patients are getting maximum inappropriate therapies? So that they say that 80% of inappropriate shocks happens in the first year of implantation. And that is mostly because of SVT, and among the SVTs, it is atrial fibrillation. So in the first year, patients are getting a large chunk of them are getting inappropriate shocks, and that too is because of atrial fibrillation. But I mean, a major chunk. So these are information that we have from large-scale registries, and therefore it becomes essential on our part to make sure that we bring down those inappropriate therapy. Now, the question that would be put is, why don't put dual chamber device in every patient? Why put a single chamber ICD? Now, that's a very common thinking that we all have, and it makes sense because theoretically, a dual chamber ICD should discriminate arrhythmias better than a single chamber ICD. But unfortunately, in a large scale data, it has been found that it is not so. Probably because of the atrial lead, sensing issue. That's the Achilles heel of an atrial lead. The sensing has been a problem, and that is why probably the studies have not shown much of a benefit or much of a difference between a single and a dual chamber ICD. Having said that, I would still say that we should all remember that in certain special scenarios, like in secondary prevention or patients who have got slow VT, we should always think about dual bar single chamber ICD. But at this present moment, recommendation is that if there is no pacing indication, you will only put a single chamber ICD. We also have now availability of VDD leads, which is a single lead, but gives information of the atrial chamber also, which has got an FDA approval. So that is another option that we have now, and we must think. Also, I must stress here to the point that while implanting a lead, especially the atrial lead, if you are doing a dual chamber ICD, we must make sure that there is no far field in the atrial channel. We should not get a far field of V in the atrial channel, because if you can do that, then you can avoid a lot of miscalculations that happens in a dual chamber ICD. So while implanting, make sure that far field is avoided, while implantation itself, then probably life will be easier later on. Now the question is, if at all we need discrimination, if at all a patient has got SVT, or a patient has got a sinus tach, or a patient has got a ventricular tachycardia, where do we think we need discrimination? Now that's the most important point. Now we know that ICDs decide therapy based on rates. Either you call it heart rate or you call it based on, cycle lengths of the tachycardia. So it is basically based on rates. Now, we all know that a rate of about 150, about 140, 150 is a zone where a sinus tachycardia, where a patient can have a sinus tachycardia and also a patient can have a VT. But predominantly it is a zone of sinus tach. Beyond 200, 220, it will be mostly a ventricular tachycardia. So these are two zones which are more or less well defined. But a zone between, that is 150 to 200 or 220, is the zone where there can be an overlap between an occasional sinus tachycardia in a young patient or an SVT with a fast ventricular rate or a VT itself. So discrimination comes in this zone, in the zone where heart rate varies somewhere between 150 to 200. So that is the zone where we should be thinking about providing discrimination algorithms to your device. Now, just to clarify, you might ask, what does this discrimination means? So what I'm going to discuss is algorithms which are meant to differentiate a sinus tachycardia, a SVT with aberration from a ventricular tachycardia. Now, these particular algorithms are called as discriminators. So I think, or rather scientifically, the zone where discriminators work best is between somewhere around 150 to 200. In that heart rate zone, you are going to apply these discriminators. Now, also, when you have implanted an ICD, the question would be how I am going to gather information. How will I know what is happening? The moment a patient has a shock, obviously patient comes to you in an OPD, and I would definitely suggest that every patient who gets a shock, his EGMs must be analyzed by the operator or by the cardiologist or by the doctor, physician who is seeing this patient, because we must look into whether the shock was appropriate or the shock was inappropriate. And if it was inappropriate, then it becomes our duty to make sure that we program again based on the patient's requirement. So this is the information that you get normally from an ICD. You have got something called as a leadless ECG. Now, leadless ECG is something very similar to surface ECG, which you will get only in dual coil ICD leads. Remember, most of the leads that we put in this part of country are predominantly dual coil. Though we are trying to shift gradually to single coil leads, but we have put predominantly dual coil leads, which has got an SVC coil and an RV coil. So the EGM that you get between the SVC coil and the CAN is called as a leadless ECG, something very similar to a surface ECG. So that is one EGM that you have for information. The second is a far field EGM, or what we call as shock EGM. Now that comes from between the RV coil and the CAN. So between RV coil and the CAN, the EGM that you get is called as a far field EGM. You've got a near field EGM, which comes from the tip to the ring. From the lead tip to the ring, the EGM that you get is called as a near field EGM. And the last is a marker channel, which tells you how the device is seeing a particular arrhythmia. The device will mark it as either an A sense, like in this case of normal sinus, it will mark as A sense, V sense, A sense, V sense, A sense, V sense. If it starts seeing any other information, it is going to show that in this marker channel. So basically, why you need to see all these EGMs is so that you can correlate that whether it is some kind of a noise, it is some kind of a lead related issue, or it is a real arrhythmia that is going on. So these are the EGMs that will be available to us while we decipher an arrhythmia that presents to us. Now, going forward, what are the algorithms that we have specifically? Now, as far as single chamber ICDs are concerned, we have got main three algorithms, what we call as onset, stability, and morphology. Dual chamber ICDs will have an additional lead, which will give information about the atrial chamber. And there you will have additional information coming from the atrial chamber. So you will have A and V association. Will have AV, VV, VA association, all that which is being given by the atrial lead. So in a dual chamber, you will have, in addition to onset, stability, and morphology, will also have more information that the atrial lead provides. So and that every device company has its own set of algorithms which uses this and defines a particular arrhythmia. Now they are all patented algorithms for a different companies, but they use both of those information in a dual chamber device. But in a single chamber device, you have mainly three set of algorithms, that is onset, stability, and morphology. Now, I think I'll just go slowly with one of these. It is very essential to understand these algorithms, because they'll make our work very, very easy when we program a device. Now, this is from Dr. Malini's paper, which was in CERC 2013. Very interesting way she has explained. Slightly looking congested, but we'll go slowly, and I think it will be easier for us to understand. Now let's look at the first thing, that is stability. Now, if you look at stability, what does that mean? Essentially, what it means is what is happening at the RR interval level. Now, remember, the physiology is that if your RR, first we'll start with onset, because that's the first thing. So onset, what is onset? The rationale is, how has the tachycardia started? Did the tachycardia start suddenly or rapidly, or it has started very, very slowly? So is it showing a warm-up phenomenon, or is it abrupt? So that particular decision is decided by this algorithm. It looks at how fast the tachycardia has started. And what is the rationale? The rationale is that a sinus tachycardia, as we all know, is going to have a very gradual onset. As you can look down, that you look at 420, 408, 396 milliseconds, and so gradually a sinus tachycardia will start. Whereas if you look up, the tracings that you are seeing, you see 600, 600, 450, and suddenly you have 240, 244, 240, a tachy starting. So obviously a ventricular tachycardia will usually start very, very rapidly, while a sinus tachycardia will always have a warm-up or a slow, gradual onset. So this is what this particular algorithm used, this physiology. And what is the level of ability of this algorithm to detect? So this is very, very sensitive, highly sensitive for distinguishing sinus tach from VT. So it will be very, very useful to differentiate a sinus tach from VT. And this is more, I would say this algorithm is more useful in a young patient where you have put a device for a primary prevention, because we know that young patients' heart rate can go, sinus rate can go to very, very high levels. So there, I think onset probably is more helpful. But of course, not in a patient who has got a VT on a lot of drugs. I think their onset as an algorithm is not very, very useful. But yes, in a primary, you might definitely consider. Now, what are the caveats? Remember that if a patient has got an atrial fibrillation or an SVT with an abrupt onset, suddenly if it starts, like something like a flutter, those things can be onset can misclassify them as VT. Second, exercise-induced VT. Many of the patients we know in longitudinal, while exercising, they will go into VT. Now, those patients where the VT starts during an exercise, again, onset will bin it as sinus tachycardia. It will miss the ventricular tachycardia. So somebody who develops a VT while exercising is definitely not a candidate where you put the onset on. So you need to know your patient well before you really start on the algorithms that you want in your device. A patient who develops VT and prior to that he's preceded by PVCs. Now, obviously, again, there will be slowing of rate, and again, the device in such cases will show the tachycardia as a gradual onset. So you need to go into the EGMs and see how the tachy is starting. What is the initiation? Whether there are PVCs falling before the tachy starts, because there again, onset will classify it as a sinus tachycardia, as a tachycardia which is gradually starting. Another problem, or rather a feature that we must remember about onset is that it is applied only once as an initial detection. That is, it will be applied once and it bins it, and that's it. It is not going to recheck itself. So if a misclassification has been done, then it cannot be corrected. It is only applied once at the starting of the tachycardia. Once it has done it, it's over. It's not going to recheck it. So what is the level of accuracy? Accuracy in rejecting sinus tach is quite high. It's about 98%. And as I just said, that there are cases where it is going to undersense VT, like in exercise-induced or PVCs. So there, data-wise, it is identified that it will be about 0.5% VT under detection can happen. So that is a place where we should always apply our knowledge that we have about the patient before we program onset. Specificity is close to 64%. Now, these are the three values that are given mainly for the devices that we normally use. Medtronic programs, the standard recommendation is about 84 to 88%. Boston is 9%, and St. Jude is 100 milliseconds. So you might get confused why values are such different. Now, the reason for this difference is is because how the device calculates is different, patented technique in different devices. So like in Medtronic, if you look at what it does is it will look at 4 beats and then it will get an average of that, and then it will subtract with the next 4 beats of the tachy that are coming. So if that is 81, suppose your program is 80% or 81%, then if the rate is lesser, 81% or below, that means the tachycardia is regular. If it is more, then that means it is an unstable tachycardia. So that is, it's a gradual onset tachycardia. So that is how it will define. So in a Medtronic device, the programming should be between 84 to 88%. Normally you can program it around 80%. Boston is 9%. St. Jude is about 100 milliseconds. Onset, use it mainly, I would say, in patients where you are using for primary prevention and where the patient has not, primary patients, long QT. So those kind of things where, sinus tachycardia can confuse. So there probably this is a good algorithm. The second is stability. Now this is important because as we discussed before, that atrial fibrillation forms a large chunk of inappropriate therapies. So what does stability look at? Stability looks at the RR interval. Are the RR intervals regular? Are the RR intervals stable, or they are unstable? So if the RR intervals are stable, that means the tachycardia is more likely going to be VT. If the RR is varying, then most likely it is an atrial fibrillation. So in a single chamber ICD, this is what it look at. Is the RR varying? If the RR is varying, and what is that variation? That the programmer will decide, that I will decide what is that value. So if it is varying RR, that means most likely it is an atrial fibrillation. If the RR is stable, it is going to be a ventricular tachycardia. So that is what the main physiology behind this algorithm. And so what does it do? It has got a high sensitivity for discriminating VT from AF, but at rates less than 170 beats per minute. I must stress it here again, at rates less than 170 beats per minute. The reason is the moment a patient develops atrial fibrillation with a fast ventricular rate, when the ventricular rate goes more than 170, it tends to organize. The RR tends to become very, very regular, and their stability may fail. The stability may give a wrong diagnosis. So which are the places where stability can give misclassify an arrhythmia? 1, in stable SVTs like an atrial flutter. 2, rapid atrial fibrillation, as I said, where the heart rate where the ventricular rate has gone more than 170. And sometimes in patients who have got an irregular VT, that is patients who are on class 1C agents or on antiarrhythmic drugs, which have reduced the ventricular rate and has made them irregular, there sometimes the RR can vary and the device might wrongly report a VT as an SVT. So these are the places where this algorithm can go wrong, and that is what we should keep in our mind when we program stability. And sensitivity is close to 95%, and sensitivity and specificity is very, very high when the ventricular rate is 170 beats or less, but it is slightly compromised when the ventricular rate goes more than 170 beats per minute. That is something we must remember. What should we program when we program? Normally, if you want to be more stiff, like in a secondary prevention, where you know that if suppose somebody has come to you, has got a shock because of AFib and not VT, there I think you try to be more strict, and there you can go down to values like 40, whereas in other cases you can keep vary somewhere between 40 to 50. So it remains so in Medtronic, so in Boston. St. Jude, the cutoff is 80 milliseconds, and again that is because how the device calculates the rhythm. And just to give you an example, because somebody may get confused how. So this is how it calculates. You see, look at the Medtronic device. Suppose you have programmed your stability as 50. So how will it calculate? The device will wait. Suppose in the device VT counter, there are 3 beats in the VT. So it will take that, it will start its stability calculation on. As you can see in this case, the third beat, the moment third beat has gone into the counter, it is 440. So it'll take that 440 and subtract from the first 3 beats. The first beat 480 minus 440, 450 minus 440, and the last beat is 510 minus 440. So it comes to about 60 milliseconds. So 60 milliseconds, you have programmed your stability as 50. So 60 is more than 50. Obviously, this is an unstable arrhythmia going on. The device will say that this is an atrial fibrillation. How does St. Jude calculates? The St. Jude device will have, it will look at about 10 to 12 beats it looks at. takes the second longest from second shortest beat in the arrhythmia counter, and then calculates the difference. Suppose here the difference is 298. You have programmed 80 milliseconds. Obviously, 298 is more than 80, so it will say that this arrhythmia is an unstable arrhythmia. So the moment RR is not regular or RR is irregular, it will be binned or stamped as atrial fibrillation. Whereas if it is regular, I mean, if the if the arrhythmia is RR is stable, then it is binned as ventricular tachycardia. Very simple. So that is what this algorithm uses. And I would say this algorithm is very, very useful, because majority of our patients who get inappropriate therapies get it because of stability. The third and the most important criteria that I'll go for is the morphology criteria. And this one is very, very important, because morphology is something that we normally program in all of our patients. Morphology is there in all our patients. So morphology must be there when you program an ICD, both in single and a dual chamber. So what is it? Let's understand. So what does morphology looks at? Morphology looks at what template the device has recorded. The device will record a template during a normal sinus rhythm. Now, when the patient develops a tachycardia, that template will be compared with the recorded template that the device has. If it matches with the recorded template, obviously it is more likely to be a sinus tachycardia or an SVT going on, because it is like patient's native QRS matches with the tachycardia QRS. So that is what it looks at, morphology looks at. So morphology inhibits therapy if the intracardiac electrogram matches the template that is stored during the normal rhythm. And we all know that if a patient has got a ventricular tachycardia, then the morphology will not match. So if the morphology is not matching, most likely it is a ventricular tachycardia. And if the morphology is matching, it is most likely going to be a supraventricular tachycardia. Now that is the basic thinking or a rationale behind this algorithm. Now, so technically, if you look at the devices, look at a lot of points. Now, it looks at about 8 areas, where the device looks at deciding on the morphology. Now, what does it discriminate? What are the caveats that the morphology can have? If a tachycardia, suppose somebody has running a SVT and it develops an aberration. Now, obviously, it is an SVT, but because it has developed an aberration, the morphology changes. So for the device, the morphology is different from the recorded morphology. And so it will record it as a ventricular tachycardia. So that is a place where the device can go wrong. An SVT can be stamped as a ventricular tachycardia. The advantage is this particular algorithm is continuously applied, and if there is any mistake, it will be able to correct it. So it is continuously being applied while the tachycardia is on. And it can also be applied in rates more than 200 beats per minute. As I said, it can misclassify when there is an aberrancy. It can misclassify if the patient has got malalignment or an abnormal truncation. So therefore, when a patient comes to you on follow-up, make sure that you look at the morphology that is recorded. You can always manually also, you can take a new morphology every time the patient comes, because that makes it more safe, so that there is no technical problem with record of the morphology. And the only thing is that it cannot be applied to redetection. Post-shock morphology criteria does not act. So it is the most accurate of the single chamber algorithms. Sensitivity is very, very high, about 100%. And it is there in all 3. Medtronic calls it, they have different names. It calls it a wavelet. Boston calls it rhythm ID. St. Jude calls it discriminator. So those are the different names. And how do we program it? What is the normal company settings that we program? It's out of 8 beats, 3 beats, if they have a morphology morphology very similar or more than 70% similarity, it will bin it as a SVT. In Boston also is 5 beats out of 8 beats. And match is about 60%. And for sub-Q ICD, just for completion, they also have a morphology score, and it is much better in that. But of course, sub-Q ICD, we have not much of, I still don't have much of experience. So I think that's something more of a theoretical discussion. So sorry, and this is what I was saying. See, this is how it calculates. The device looks at multiple points, it puts in the template, takes the VT tachycardia template, puts it on it, and tries to compare what is the difference. In the dual chamber ICD, if you look at a dual chamber ICD, then what is the advantage that we have? Now, as we all know that in a dual chamber, very simply, you look at number of V's and number of A's. If V's are more, it's going to be most likely going to be a VT. If V is equal to A, then role of discriminators come in. You can apply a morphology criteria, which may be sufficient. That is, if there's 1:1 V to A, if V and A's are 1:1, then probably you apply a morphology criteria and then decide. If morphology is same, it is an SVT. If morphology is different, probably VT. And where A is more than V, you apply both morphology and stability. Morphology is matching, most likely SVT. And if it is irregular, very, very likely that an atrial fibrillation is going on. So that is how the device differentiates. And in different different algorithms that are there under different device companies, like Medtronic calls the PR logic, where the device looks at both VV intervals, look at AA, VV, and AV logics. And as we have just discussed, if V is more than A, it's going to be most likely VT. If A is more than V, it will look at morphology and stability to decide on what is the arrhythmia going on. St. Jude also follows the same algorithm in a slightly different way. And the advantage or difference in St. Jude is that as a programmer, we have the choice of deciding whether we want all the algorithms in the programming. That is, you can put it as all, you can put as any out of all, or you can put 2 out of 3. So those kind of changes you can decide based on what pathology the patient has. If a patient has got secondary prevention criteria, then I think we have to be more aggressive. We can put probably 1 out of 3. If a patient is having primary prevention, we can probably put all, all, yeah, so that, you know, we avoid inappropriate therapies are reduced. So those are the different things that you can do while you program your device. This is a Boston algorithm, and rhythm ID, there is not much of scope in playing with the different values, because it is a fixed algorithm. You can switch it on, and this is how it works. It also looks at same V rate and A rate. If V rate is more, it stamps it very simply as ventricular tachycardia. If V rate is not more, then it applies the morphology criteria and decides on if the morphology is same, it is an SVT. If morphology is different, it is going to be VT. So that's how it differentiates. Now, very quickly going on to some additional things that we should keep in our mind while we apply a discrimination. Now, one thing we all know is most of our ICDs, we are able to program ATPs. Now, if some of your patients have received an ATP, then what you can do is you can use the response of that ATP while you are looking at the EGMs. Now, how can you use it? Suppose a patient is having a tachycardia running at 280 milliseconds, and your device has delivered a burst pacing at 240 milliseconds. Now, if that burst pacing has terminated the tachycardia, then most likely it supports VT. If suppose you have delivered a therapy, I mean ATP has been delivered and it has caused an AV dissociation, and A rates, you can very clearly see the A is more than it has opened up an atrial tachycardia. It has rather unraveled the atrial tachycardia that was running in. The other thing that you can look for is sometimes we call as entrainment. Now, suppose, what is entrainment? It is basically a more of a electrophysiology principle, but I'll quickly try to put a few points, few words on it. Is suppose 280 milliseconds is the tachycardia running. I have the device delivers a burst pacing at 240 milliseconds, and if it accelerates, suppose it's a V to A is going at 1:1. You have your burst pacing is delivered at 240. It is able to take the atrial rate to 240. Then in that case, what response happens at the end of ATP can tell you the diagnosis. If it is a VVA response, we call it the VT. If it is a VAAV response, called an AT. Maybe it is slightly complex, but what I'm trying to say is, if you look at ATP and how the ATP has, what the ATP has done to the tachycardia can also be used to define or differentiate the mechanism of tachycardia. So this probably might require some more discussion. If somebody is interested, we can always discuss on that. Now, certain point, this point also I want to discuss was about timers. Now, always remember that you can put some timers on in your device. There's something called as SVT timeout. That is, if you're supposed programmed a time of about 20 seconds or 15 seconds or 10 seconds, what the device will do is, even if it has diagnosed as an SVT, at the end of 15 seconds, it will deliver the therapy that is there for a VT. So that is called an SVT timeout. Same you have got for VT timeout. Now, the point that I'm trying to make here is, you program a timer only when patient has got a poor LV, or you think that the patient is not going to tolerate, hemodynamically, the patient is not going to tolerate the arrhythmia. I think that is the point where you should put timers on. Otherwise, it's better to switch off the timers. The timers are not, because otherwise, many a times, they're the ones which are responsible for delivering inappropriate therapy. So put the timers on only when you've got a poor LV and patient is not going to tolerate the arrhythmia. A quick point about sub-Q ICDs. Sub-Q ICDs, as we all know, do not give much information because it's all outside. But what it does is, it is able to give you much better morphology because of the subcutaneous electrodes that sub-Q ICD has. So it has got 3 sensing vectors obtained from 3 subcutaneous electrodes to record electrocardiograms. It is very good in delivering morphology because it looks at about 41 points, and so probably morphology-wise, sub-Q ICD is able to provide much better information. But I think it is still an evolving science, and data needs to come before we actually know how to define sub-Q ICD and how to troubleshoot them. Now, quickly going to some 2-3 cases. This is more for discussion. 60-year-old male, ischemic DCM, had a single chamber ICD, presented post-shock from the device, and how do we define it? Now, let's see what next. So the moment we see this EGM, we get a lot of information from this EGM. Now, this is a single chamber ICD we know very well. The ventricular EGM is clearly showing a cycle length of 360. So this is a programmed cycle length. We know that definitely the arrhythmia is going on, and it is most likely a ventricular arrhythmia. Now let's go and see what's happening. An ATP has been delivered. What kind of ATP? See, very clearly it is a ramp ATP that is being delivered. 260, 250, 240, 230, 220. So it's a ramp, it's gradually coming down, ATP with a gradually coming down cycle length, which has been delivered. And what has it done to the tachycardia is that, after the end of it, if you look at the tachycardia still continues. So the ATP is not able to terminate the tachycardia. Then what has happened is that the tachycardia tends to continue, and the device delivers a shock, about 4.7 joule shock, and the tachycardia terminates. So this particular, the information that we get from all of this is that yes, this device is able to discriminate well, is able to identify the tachycardia well. ATP is probably not effective. A ramp ATP is probably not effective in this case. We need to program either a burst ATP, or we need to program cycle lengths of different ATP that we must do in this case. And 3, that probably the device discrimination has worked well. Another case, 72-year-old male, non-ischemic cardiomyopathy, intermittent complete heart block, received a dual chamber ICD, presented with ICD shock, and let's look at what's happening. Now, this is a dual chamber ICD. Now, our work is made much, much easier. So the moment we see both EGMs, we look at the atrial EGM and we look at the ventricular EGM. So it's very, very clear. Look at atrial EGM. You have got much less A's running. You've got much higher number of V's running. So as I said in our discussion, moment you have got more V's compared to A's, it is nothing but a ventricular tachycardia running. So as you can see very clearly, cycle length of 310, 320, 310, 320, more of V's, less of A, cannot be anything but a ventricular. So definitely the device has identified the tachycardia correctly. So that is surely done. Second, what has it done? It has delivered an ATP. And if you look at the ATP, it is a burst ATP delivering at 270 milliseconds. That is about 50 milliseconds less than the tachycardia cycle length. And what has it done? Terminated the tachycardia. So from this EGM, I am very clear that the device has identified the discriminators are programmed well. The device has identified the arrhythmia correctly and has been able to deliver a therapy which is also correct, and it is pain-free. So this particular EGM, if I look at, I think overall I will be more happy, and probably I'll program more ATPs in this case so that he receives less of shocks, and it is a pain-free therapy that I'm going to deliver to this patient. So that is the whole idea of looking at EGMs and deriving, kind of informations from these EGMs. And this one is probably the last one. A 60-year-old gentleman suffered an anterior wall myocardial infarction and underwent PCI, had a severe LV systolic dysfunction, EF of 32% at 4 months, showed evidence of sick sinus syndrome, and underwent a dual chamber ICD. He had an ICD shock. And what do you think is the etiology? His programmed is stability and morphology, both are programmed, and is programmed at any. I mean, so either of that it's going to deliver. So that is how it is programmed. Now let's look at the EGM. So the top is the RA channel, bottom is the RV channel, center is the marker channel. As you can see, the device is seeing it. And what is the device seeing? As we can see, the device is looking. So very clearly, we can see that in the atrial EGM, the P waves are much, much faster. The V rates are slightly slower. So if you ask me, even without looking much deeper, I can say that it's probably an AFib running. So the device is correctly, so the ticks that you see here in the top, there are some tick marks. The tick marks are nothing but morphology. So the device is monitoring the morphology, and the morphology is matching, which basically means that an SVT is going on. So the device is correctly identifying that an SVT is going on. So top RA, atrial rate fast, ventricular down, it is clearly identified that an SVT is going on. So continues like that. But towards the end, as you can see, that it has triggered and delivered a shock. Now, the question is, obviously it's an inappropriate shock. Now, what do I do as a programmer? What next extra I should do? So now I look again at the EGM and I find that the morphology criteria is working well. But what has happened is that as the tachycardia rate, the ventricular rate has increased, as I said before also, moment the ventricular rate has increased, the stability criteria, which was showing previously as an SVT, changed because the RR became more stable. So it showed it as a VT and delivered the therapy. So here we have programmed the device as any. Any means either morphology or stability. Either of this, if it is showing it as VT, we have asked the device to deliver a therapy. So the device has delivered a therapy in spite of it identifying that it was morphologically an SVT going on. But as the rate went up, the RR interval became more regular. Stability criteria came into the picture. It said that the tachycardia is more stable, and so thus it has delivered a therapy. So that is the reason, that is the lesson that we have learned from this, and we will have to probably work on this. Maybe we'll have to put it as both and reduce his chances of getting shocked. So, and this is the way probably we need to work on. This is the last case, 57-year-old non-ischemic cardiomyopathy, EF of 20%, ICD for primary prevention. He has got a single lead device, this is the Biotronic one, the VDD. Several months after implant, he presented with the recurrent shocks. It caused fear, anxiety, and a sense of impending doom. And let's look at what we are getting. Now let's see what is happening here. The first one tracing, if you look at the VT, you look at the RR intervals, they're definitely at about 289, 290 milliseconds. So very fast ventricular rate. Obviously, it's a tachycardia going on. Now, what we see in the atrial channel is, we see that atrial channel has also got signals simultaneously coming on with the ventricular channel. So both atrial and ventricular channel has got signals coming simultaneously. Now, is this a possible, what are the possibilities? Can it be a VA running? VA, yes, but then they are so simultaneous that it's very difficult for a VA to come like this. There has to be some gap between that. So next look at the next what has happened. Next, you see that it has again delivered a therapy and burst spacing by the device. So the device saw it as a VT, delivered an ATP, and the tachycardia terminates. And again, the same thing has happened. So if you look at these EGMs, from the EGMs, it's quite clear that both V and A are simultaneously coming. And they are so simultaneous that this particular A is falling in the ventricular blanking. Hello? And so the device, for the device, it is probably a VT running, and so it has delivered a therapy. And so what actually was happening in this case was, it was an AVNRT. As we all know, it's an A on B tachycardia running, which was ablated and the patient had relief. But in this case, because the device is not able to see that, the VA is falling in such a short range that the device saw it as a VT and has delivered a therapy. So that is the whole idea of looking at discriminators when we look at the device after a shock. I think thank you, and we can discuss if there are any questions. Yeah, Dilip, thank you.
Yeah, excellent presentation.
Excellent.
Yeah. So can I ask two, three questions? Like
Yeah.
in your last case, the morphology discriminator was not used by the device, number one.
Yes.
And what are the situations when other discriminators will be asked to shut off? Like there is a, when the heart rate goes
Yeah,
up.
good question. Like I said, like suppose, agreed. Like suppose, see, if you are putting a device for a secondary prevention, patient has got a VT and you have put a device, then I think onset criteria can be just kept as a passive because it is not required. Onset is going to confuse the device. So in a secondary prevention, where your rates are, your sinus tachycardia is not going to confuse you with a VT, I think onset can be just kept at passive. Whereas in a primary prevention, the long QT you have put a device, probably onset may have a role. So I think that's
yeah, it says here, once the rate goes in a VF zone, then
yes.
then this morphology discriminators will not be used, and other discriminators will also not be used. So once in VF zone, it will just see the rate and deliver the
No,
shot.
that's what I'm saying. See, that was the first slide I showed, that you can apply discriminators only in that VT zone, in the rate that I said 150 to 100, that zone only you can apply. Moment you have written VF and that rate you will decide as a programmer. In VF zone, you cannot program a discriminator, except probably in Medtronic. In no other device you can program. So the device is going to deliver therapy. So you can only program discriminators in the VT zone.
Tell us something about committed and uncommitted shocks.
Yeah, perfect. Now, see, thing is, now previously, when in the initial phases when ICDs were coming, all shocks were committed. That is, moment the device has put a diagnosis of VT, it is going to deliver the therapy. Though it was never going to look back what is happening. But now the device goes for ATP charging. While it is charging, it confirms again whether the arrhythmia is the same. And if it finds that, it's called a reconfirmation. If it finds that it is not, the arrhythmia has terminated, then the shock will not be delivered. So that is called as a non-confirmatory therapy. I mean, the device is going to recheck and deliver if it finds that the tachycardia is still going on. If the tachycardia is terminated, though it is charged, it is not going to deliver therapy. So that's a non-committed therapy, which is now available in the newer generation devices. Yes.
Sunandan here.
Yeah, Sunandan, tell me please.
Sanjeev, Sunandan
Yeah, tell
here.
me. Yeah, Sunandan, tell me.
One question is, in case of a scarred myocardium, many times the R wave is very small and almost equal to the T wave. So how do you program a device so that the double counting does not take place?
Yeah.
Double counting
See,
does
thing
not
is,
take place.
I understand, yes. See, my topic was mainly between SVT and VT. That's why I think I've not brought in those T waves and all. But as you know that in St. Jude devices, you have got a decay delay happening. You know, the algorithm is already there with you. Second, I think it is also important when you implant the device. That time, I think it is very essential to look at whether you have got a T being oversensed. Those things you do at the implant time, and later on you can obviously use these algorithms like decay delay in St. Jude, or else you can reduce. You can if your R wave amplitude is not good, in that case actually you're going to be in trouble because you cannot come down much on your sensitivity. But then I think you'll have to get a safe zone, whichever way you're going to get. But I think that's a difficult scenario. Practically, it is always going to be difficult. Anything specific you want to say? Yeah.
Dr. Sanjeev, can I come in? Can I come in?
Yes.
I think Sunandan, the best answer for this lies on your table only. As compared to a pacemaker, an ICD needs a good R wave because the sensing is the backbone of a ICD. So if you're not able to get a good R wave on table, then from there only your troubles are going to start.
Yes.
Because if you don't have an R wave, that means you will not be able to change your sensitivity. If you have a T wave over sensing, you can't do anything about your R wave because your R wave itself is 4. So one of the methods there is the intrinsic mechanisms and which sir already mentioned is the decay delay. But then there are mechanisms now where they are comparing the R and the T wave, and they are amplitude changes in the R and T with time. The device itself has like you have a decay delay in the sensitivity of the R wave. The T wave as well as the R wave comparison also have a sensitivity, so that the device itself amplifies the T wave and decreases the. There are inbuilt mechanisms where you have the T wave decay itself or the R wave decay delay itself, which are there. But I think there are so much intrinsic to the device. The best thing for a device is a very clear thing, which is that you need to have a good R wave. But yes,
Good R.
sometimes if you have a cardiomyopathy, you might not get it. So always there's going to be trouble with any person not having a good R wave.
Because many times the disease progresses and the R wave may change. Gradually, the cardiomyopathy progresses and you can have a reduced R wave later also. That is one problem.
True.
We
True,
faced
absolutely.
one problem with a T wave in hyperkalemia. Patient
Yes.
had hyperkalemia, T wave became tall, and then double count is started. That is
Yes.
another thing, another problem.
Absolutely, absolutely. The only other thing, probably some amount of you can play with also the PVAR, but that again you have got limitation. You know, you might actually start undersensing the tachycardia itself. But those are the things you can do only. I think nothing much that you can do in that case. Yes.
One more point, Sanjeev. If
Yes.
we are if we are making while taking the template for the future morphology,
Yes.
we need to see that it's not clipped. If the
Yes.
clip, then it will always find that its VT is going on. Morphology is
Yes.
these are very
That's what I said. Both truncation and
truncation.
clipping is again something that might make the whole algorithm go awry. So therefore it is important that we do it. And if you think there's a problem, take it manually. We can always record a manually when the patient comes to you for follow-up. So that way you can do it. Many times we find that patient has developed a bundle branch block later, but the device, nowadays the device actually automatically takes in. But if it doesn't, it's better to manually put it, because then otherwise it will again, wrongly interpret the arrhythmia.
Actually,
Yes.
it was device itself. It is modifying its templates nowadays.
Yes, now they do it. Yes, that's what.
And Dr. Sanjeev, one more point. If you talk about a dual chamber ICD,
Yes.
the indication which you very clearly pointed out is an requirement of pacing. But one of the very important places.
Your voice broke. Yeah. Once more,
Yeah.
please.
You said that the requirement for dual chamber ICD is mostly and when you have a requirement of pacing. But one of the very important areas where you might require a dual chamber is channelopathies, where you want to stay high on the beta blockers. There also you can still think about. And the third is HOCM, where so Nandan which brought up the T wave over sensing everything. The discriminators also act very well. If you have a dual chamber HOCM, you might require more. So the other indication for a dual chamber ICD can be channelopathies with high dose beta blocker. We give you a liberty to use them, or probably HOCM also, where they tend to, the pacing, the simultaneous pacing also is known to decrease the LVOT gradient.
No, I agree to a point. That's what I said. See, when I say this, that even in fact, in secondary, there are trials which have shown that in secondary prevention also, dual chambers have done well. But the thing is, at this moment, recommendations are only when you do when you require pacing. And as you said, in both these cases, where you're going to be aggressive with beta blockers, you're going to bring down rates, you will require pacing. So I think you're justified in saying the same thing, that probably there'll be required pacing and so dual chamber.
Yeah.
But per se, if there is no indication of pacing at this moment, also we still talk about a single chamber. That's what I meant actually.
So thank you. I think we have exceeded the time 2-3 minutes, and I thank again Dr. Sanjeev Kathuria, Dr. Bikash Majumder, and Dr. Sanjeev Mukherjee. And next week 7 o'clock we will meet again with a newer set of presentations. Thank you, Bikash boss, again, and Sanjeev.
Okay, thank you.
Thank you very much. Really nice.
Thank you.
Okay, thank you very much.
Thank you so much.
Thank you. Good night.